Thank you, Dr. Caselli, and I'd like to thank Dr. Griep and Dr. Landsman for the opportunity to present. It's always an honor and a privilege. I think as a good follow-up to hypothermic circulatory arrest, I'd like to discuss selective cerebral perfusion in aortic arch surgery. First, it's always good to give a little history, just to know where we've come from as we move on today. And we'll talk a little bit at the formulation, and then unilateral versus bilateral, and then lastly, just a mention about the spinal cord. I think Dr. Griep has touched upon that somewhat in a more extensive way. This is probably one of the first series of aortic arch replacements formed and published by Dr. DeBakey in 1962, and as you can see, there were two methods for aortic arch replacement. There was sort of a passive shunt method on the left, and then on the right, in many cases, using bilateral carotid artery perfusion with normal thermic blood. There was no stroke rate published with this series, but this is about 138 patients all the way back in 1962. This, I think, is the first example of axillary perfusion. This was published from Dr. P.K. Sen's group in what was then Bombay, and he did a preemptive right subclavian to left common carotid artery bypass, and then using a combination of axillary perfusion and femoral perfusion was able to do aortic arch resection using selective perfusion. This is a paper from the Stanford group at about the same time as Dr. Griep published his landmark paper, looking in their first 10 patients using actually unilateral selective cerebral perfusion with moderate hypothermia. And what was remarkable for this series, there were no strokes, and 7 out of 10 patients survived. And really, as we all know, Dr. Kazui began to popularize this technique of selective anterogate perfusion, publishing his first small series in 1989. And he actually reminded me that he first published it in 1986 in the Japanese journal. So this is really the first beginning of his very extensive experience. And then, of course, we all know Dr. Bachet's series published also in 1991, looking at their first 54 patients. This is a technique first published by Professor Gilmay in 1986, using very cold selective cerebral perfusion in both common carotid arteries, with excellent outcomes, very low stroke rates. So really a benchmark under which we continue to try to improve. So what's the best way to look at this? I think it's to break it down into what's the best perfusion pressure, what's the best flow, what's the best temperature, what's the best pH management, and finally, what is the ideal hematocrit. So in terms of perfusion pressure, I think one of the greatest studies looking at this, whether it should be low or high, was from Dr. Griep's group, looking at a porcine model, 3 groups, 50 millimeters of mercury, 70, and 90. Looking at cerebral blood flow, you can see that the high pressure group has the highest cerebral blood flow. But what's interesting is that all the groups have the equal degree of cerebral metabolic suppression. And at the highest pressure group, once they're reperfusing off cardiopulmonary bypass, has a higher cerebral metabolic rate, which may be indicative of some type of cerebral injury and that there's some debt that needs to be repaid. That being said, when you look at intracranial pressure in those animals, the highest perfusion pressure group had the highest intracranial pressure. And when you look at the neurobehavioral recovery, the animals in the 50 millimeters of mercury group recovered and had a sustained recovery as compared to the higher pressure group. So one needs to keep that in mind. Well, what about the flow? I mean, the pressure is one thing, but some people say we have to look at the flow. And there was a nice study done looking at 2 groups of animals, 8 cc's per kilogram versus 18. And once again, you see there in the pressure group related to the flow is that they also had very high pressure in their high flow group. And this also translated to high intracranial pressures. Intracranial pressure, elevated intracranial pressure has been a marker for poor neurologic recovery. And you look at the different areas of the brain, and you can see that there's probably a luxury blood flow in most areas of the brain in the high flow group. So unnecessary, perhaps, flow that could lead to a higher risk of embolization. And also, when you look at the intracranial pressure and the sagittal sinus pressure in those animals, once again, the high flow group has the highest pressures. This is a nice study published in 1995 looking at a model in the canine at 25 degrees for 90 minutes. And what these investigators did is they established a baseline in their animals, and then they did a sequential decrease looking for the lower limit of flow. So they started at 100%, then went to 50% and down to 25%. And then they used somatosensory evoked potentials to attempt to determine what was the lower threshold. And what you see there is once you got to 25% of the baseline, you started to see some delay in the SSEPs. And when you look at those animals after sacrifice, the histological injury is mild, but still there is some evidence. Whereas when you're at the 50% level, there was no evidence of cerebral injury. So this kind of starts to establish the lower end of flow. This is a nice study published recently from Johnson and their laboratory, and they used a baseline of 8 cc's per kilogram per minute at 20 degrees. And what they did is they sequentially decreased flow down to 2, 6 to 4 to 2, looking for the threshold, and they were able to show that you had increasing lactate levels once you went below the 6 milliliter per kilogram threshold at 20 degrees, and you also saw that the venous saturations began to drop as well. So that kind of gives you an idea of what's probably the best flow and what the upper and lower limits are. Well, what about temperature? I mean, this is always a bit of a controversy as everyone's looking to do surgery at a warmer temperature. I think there's a very, very nice study done. I think this is the Hanover group. They had 4 groups of animals, hypothermic circulatory arrest, animals with selective perfusion at 10 degrees, animals at 20 degrees, and then animals at 30 degrees of selective perfusion. And when you look at the intracranial pressure, you can see that the 30-degree animals really had the highest intracranial pressure, which was significantly greater than all the other groups. And then even during reperfusion, that difference when compared to the 20-degree animals was still significant and considerably higher than baseline. And when you looked at sagittal sinus saturation, one could see that these saturations were the lowest in the 30-degree selective cerebral perfusion group. When one looked at EEG recovery in all the 4 groups, you can see that the 20-degree group had the best EEG recovery. So perhaps that selective cerebral perfusion at 20 degrees is perhaps the best temperature based on this study. What about pH management? This is somewhat controversial. Again, this is from Dr. Griep's laboratory, looking at 2 groups of animals, one in pH stat and one in alpha stat management. And as you can see on the left side, that the cerebral blood flow, as to be predicted in the pH stat animals, was higher, perhaps too much so, producing somewhat of luxury perfusion. When you look at the metabolic suppression of the brain, you can see actually that the alpha stat animals were perhaps had a little bit of improved cerebral metabolic suppression as opposed to the pH stat animals. And the neurologic recovery, pretty close to the same, but sort of a trend towards a better recovery in the alpha stat animals. And so one of the concerns is that you have this increased flow, and does this expose the brain to excess flow and therefore possibly increased embolic load? And if there's an increased flow, is there an increase in intracranial pressure and perhaps a poorer outcome? So the conclusion of this paper was that we should continue with alpha stat management for selective perfusion. That being said, this animal study done from Japan looking to develop what they call a chronic infarct model for selective cerebral perfusion, and what they did is they were able to show that there's in patients with previous animals with previous strokes, that there was evidence of chronic ischemia around the penumbra of the previous stroke. And you could see that there was elevated glutamate concentrations, which were indicative of this local cerebral injury. And then what they did is they applied pH stat and alpha stat to that group of animals with chronic infarcts. And what they're able to show is that the pH stat management was able to attenuate some of that chronic ischemia around the infarct, and suggesting that perhaps in patients with old infarcts that a pH stat management would be better than alpha stat. However, this has never really been shown clinically. Well, what about hematocrit? Again, from Dr. Griep's lab, looking at 2 groups of animals, 20% versus 30%, And again, as you see on the left side, the low hematocrit animals had a higher cerebral blood flow. But when you looked at cerebral metabolic rate for oxygen, there was really no difference. Intracranial pressure had a sort of a trend towards higher intracranial pressure with lower hematocrit, but certainly within the limits of physiologic parameters. However, when you looked at the neurobehavioral recovery, it was better in the high hematocrit animals. So the question always comes up is there better unilateral versus bilateral? And how does the circle of Willis play into all of this? Well, this is an often quoted paper from McCullough looking at anatomic study of the circle of Willis in I think it's 80 some odd patients or autopsies. And what he used was a 0.5 millimeter threshold looking at the anterior communicating or the left posterior communicating artery as the threshold for which there was insufficient flow through the circle of Willis. And what they found was basically that about 14% of these autopsy specimens had a circle of Willis that was incomplete and would be somewhat detrimental with unilateral cerebral perfusion from the right side. And their recommendation was that CT angiograms of the circle of Willis should be done to identify those high-risk patients so that you could use left carotid perfusion. And this is an interesting study from a group in Eastern Europe where they had actually 42% of the specimens showing some kind of anatomical variant that made them very concerned about unilateral perfusion. And they came up with this whole scheme about what the potential vulnerable areas of the brain might be. And you could see there that you could have quite a number of different types of ischemic stroke based on unilateral perfusion. Fortunately, clinically, we don't see this. And one of the most recent studies by Dr. Urbanski looking at unilateral perfusion in 99 patients from the left common carotid artery. Now, mind you, these were short periods of selective perfusion. They did pre-op CTAs, but they only found a complete circle of Willis in 60% of the patients. They monitored with transcranial Doppler, SEPs, EEGs, and they only had one stroke. So good news certainly for unilateral perfusion. Keep in mind this is a very short period of circulatory perfusion. So his conclusion was that the extracranial circulation must play a very important role in perfusion of the left side or the right side, depending on which side you perfuse, and that CTA of the circle of Willis was probably unnecessary. And this is a large series from the Emory group, looking at their experience with unilateral perfusion, moderate hypothermia, 30 minutes plus or minus 15 minutes, and excellent results. And when you look at their series, it's really a combination of hemiarch and full arches, but perfusion time was not a predictor of mortality and poor outcomes. And then the follow-up series by Dr. Urbanski in his large series of 347 patients, again, 34 minutes of moderate hypothermia, but unilateral perfusion, right or left carotid or the innominate. Again, excellent results, very low permanent neurologic injury rate with unilateral perfusion. So, do we need to do bilateral perfusion on any of the patients? Well, this was a very interesting study that was done from Bern in actually Switzerland, where they did follow-up studies where they did quality of life on their patients, and what they found was if you had unilateral perfusion and you did a quality of life survey, you found that it was somewhat inferior to those that had bilateral perfusion when your perfusion time was greater than 40 minutes. So now we're starting to tease out, perhaps if you need to use selective perfusion for a very long period of time, perhaps bilateral is better than unilateral. And then lastly, this was sort of a culmination of a number of manuscripts looking at neurologic injury rates less than 5%. And again, if you had a prolonged period of antegrade perfusion, perhaps bilateral is better than unilateral, and that was their recommendation. Lastly, I just want to mention, and Dr. Griep touched on this just briefly, but this was a paper from the Hanover group and looking at their series of moderate hypothermia versus deep hypothermia. And when you do a subgroup analysis of this large group of patients, and you look at the moderate hypothermia group with lower body ischemia greater than 60 minutes, you see that they had 2 incidents of paraplegia or 18% paraplegia rate. So this was a little bit concerning in the moderate hypothermia group. And this led to the study, as Dr. Griep just mentioned, where they looked at spinal cord blood flow with selective cerebral perfusion. And what you see, as mentioned before, is that below T8 there really is no blood flow to the spinal cord during selective cerebral perfusion. And using this data and the data from the previous studies on hypothermia and cross-clamping, one was able to develop the, quote, safe zone for the lower body during selective cerebral perfusion. And I think this is a very, very important paper when you're planning your operative procedure to decide how long is my lower body going to be ischemic, and therefore choosing what temperature I'm going to use. And if I feel it's going to be a prolonged period, then perhaps have some way of perfusing the lower body while I'm doing the aortic arch reconstruction. So a very, very important paper. So in conclusion, what is the best formulation for selective cerebral perfusion? Well, I think a perfusion pressure should be in the range of 40 to 60 millimeters of mercury. I think your flow should be 6 on the lower end and 10 milliliters per kilogram per minute on the upper end. I think core cooling is going to depend how long you're going to be arrested. If you're doing a hemi-arch, you're going to have a short period of arrest. You probably don't need to cool quite as much for the body. Selective cerebral perfusion, I still believe that you should stay relatively cold. I think warmer perfusion doesn't give you the kind of a buffer if something goes wrong and you need to interrupt circulation. pH management at this point, and this is not probably done, but alpha-stat at this point. I think the hematocrit, even though in an era of trying to use less blood, hematocrit should be a little bit higher. I think it's a little bit better for the brain during selective perfusion. I think near-infrared spectroscopy is key, as mentioned by the previous speakers. I think it's a very easy way to monitor the brain during perfusion. If your selective perfusion time is going to be greater than 30 to 40 minutes, consider using bilateral perfusion if you usually use unilateral. And then your cannulation options are considerable. I think all of them have been used with excellent results. The one caveat is I would make sure that the subclavian artery, left subclavian, is occluded. I think there is a Steele phenomenon. And then lastly, limit your corpus and spinal cord ischemic time based on temperature. I think is very, very important. Don't forget about the spine. So to quote a friend, this is a very nice review paper in the cardiology clinics by Dr. Bichet. What is the best method for brain protection and surgery of the aortic arch? Selective cerebral perfusion. And the only addition I have is that to keep some degree of hypothermia. Thank you for your attention.